Good morning, everybody. This next lecture is on the ankle and lower leg. This is continuation of Chapter 7. Previous lesson was on the toes, the feet, and the heel x-rays. And so now we're moving up the leg toward the hip. The next section, ankle joint, the joint that joins the foot with the lower leg, and then of course the tibia and the fibula, lower leg exam. The ankle, the knee, I would say it's probably 50-50, or actually 1/3, 1/3. So the joints of the lower leg, they will wear you out radiographing these things. You will definitely see lots of ankle x-rays in your time as an x-ray tech. It's just one of the parts of the body that tends to get injured a lot, especially with uneven ground and in the wintertime, icy conditions or slippery surfaces, rolling an ankle or twisting an ankle or taking that a bit further and getting a POTS fracture. Seems to be all too common, and we'll never run out of ankle x-rays to do. So, all right, anyway, getting into it, same thing we always do. We're going to talk about the anatomy first. We're going to go through the anatomy of the ankle, the anatomy of the tibia and fibula. We'll talk about procedural considerations. Then we'll talk about radiation safety practices. And then we'll get into the description of the specific positions, positioning aids that you might use during these positions. And of course, we're going to follow up this recorded lecture with a lab where we actually try these positions on each other, and I demonstrate the positions to you. And then you in turn demonstrate them to me, all in preparation for a practical evaluation where you may have to demonstrate proper positioning of ankle or lower leg projections eventually. Okay. And then wrapping up the module, we'll do image critique of the ankle and the lower leg as we prepare for the quiz. So 4 or 5 touches with the material planned for you. If you do 2 or 3 additional touches on the material or repetitions with the material, that'll be 7 or 8 repetitions before the quiz being another repetition, and then should be well on your way to pushing this into your long-term memory if you follow the game plan. All right, so the ankle joint, it's formed by the talus, which is the most superior tarsal bone, and the bones of the lower leg, specifically the distal anatomy of the lower leg, the malleoli, that's plural, malleolus, club-like projection is singular. You have 2 malleoli on each leg. You have a lateral one and a medial one. The lateral one belongs to the fibula. The fibula just terminates in the lateral malleolus. And then the tibia, that's more of the tibia, the medial malleolus on the tibia looks more like a styloid or an aggressive, like supersized styloid than it does a club. But the lateral malleolus definitely looks like a club. And then, of course, the inferior surface of the tibia is the articular surface that that sits on the talus bone and forms the proper ankle joint. Okay. So here is our ankle joint. That is tucked in posterior to the tibia. Fibula resides lateral and posterior to the tibia, typically at both its anterior and, or I'm sorry, at its superior and inferior ends. And so the Mortise is actually the squared off joint space that forms kind of almost a rectangle shape, or a lowercase h shape. You'll see that on the Mortise view. You'll see a lowercase h joint space, and that's an open Mortise view. But the Mortise joint is the entire space going from between the medial malleolus and the talus to the inferior surface of the tibia and the talus, all the way over to the lateral malleolus and the talus. So it wraps around, the Mortise wraps around the entire top of the talus bone. Okay. The ankle joint is a hinge joint, even though we do see it looks like pseudo-rotational motion, but that's actually a combination of the gliding motions of some of the tarsal bones produce that rotational motion of the ankle. It's not really a true rotational motion at the ankle joint. The ankle can only flex and extend. So slight adduction, abduction, and rotation motions of the ankle are results from the gliding movements of the intertarsal spaces rather than the ankle joint itself. The ankle is a hinge joint, very much like the elbow joint is a hinge joint. And so a combination of those motions produces what looks like ellipsoidal motion at the ankle joint, but it's not. It's not a true ellipsoid, it's a hinge joint. All right, general procedure guidelines, patient preparation, socks and shoes off. If they're wearing an ankle bracelet, you don't see those often anymore, but an ankle bracelet would have to come off necessarily. General patient position, you're typically going to do your ankles and lower legs with the patient on the exam table or in a stretcher, recumbent. Your collimated field size, 10 by 12 for your ankle joints, 14 by 17 might have to go, depending upon the size of your patient, you might have to go superior and inferior projections for the tib fib, the lower leg projections. So your SID is 40 inches, but you can do, with a tib fib, there's a trick you can do a greater than 40-inch SID to reduce magnification, and it might make the difference of fitting it all on one cassette for some of these lower leg exams. And so I'll show you those tricks in the laboratory. ID markers, people have left and right ankles typically, and there's a distinct difference between a left and a right ankle, and we don't want wrong side surgeries, so we have to use radiopaque markers. That is the legal standard. Radiation protection, the anatomy of interest is well away from the reproductive organs, the gonads, so there's no reason not to shield each and every patient for an ankle and lower leg exam. No special breathing instructions, but your patient does have to hold still, which in the case of trauma, sometimes that can be challenging, especially at the ankle. The ankle can literally crumble and fall apart into many, many pieces. Comminuted fractures are common at the ankle because of the torque of the injuries involved. All right, so essential routine projections of the ankle. There's going to be an AP, a lateral, and obliques. Now there's two ways to do obliques of the ankle. You can do straight 45 obliques, which are not as diagnostic, but the more common oblique is called the oblique for Mortise, or the Mortise oblique. And that involves 15 to 20 degrees of medial rotation to the ankle joint to open up the entire joint space of the ankle joint, including the distal tibiofibular articulation. All right, so starting off with the AP ankle, pretty straightforward. The patient's going to be laying supine. Toes are going to be placed pointing toward the exam room ceiling, if possible. Now, if they've had trauma, we square up the knee, not necessarily the toes, because in the case of trauma and a fracture at the ankle, the foot can actually be diverted from its anatomic position. And I learned that lesson right up in my face as a senior student at Vanderbilt. When the foot was AP, the knee was actually medially rotated 45 degrees. That's how bad the foot was messed up and how bad the ankle was fractured. And so don't use the toes as guidance for whether or not the ankle is AP. Use the knee and the lower leg as guidance as to whether or not the ankle is AP. The foot may be deviated if the injury is bad enough. Leg extended, the knee is going to be straight, ankle centered, unmasked part of the IR, that's kind of obsolete. We're only going to shoot one projection on one image receptor to avoid any kind of processing errors. You are going to dorsiflex the ankle if the patient is able to do so. Make the plantar surface of the ankle vertical, and then you direct the central ray to a point in between the malleoli of the ankle, which are the two bony prominences on the medial and lateral aspects of the ankle. Okay, our collimated field, 1 inch on the side of the ankle, 8 inches lengthwise, so that is centered at the joint, goes superiorly from the joint about 4 inches, and inferiorly from the joint about 4 inches, which should get you right to the plantar surface of the ankle. With the foot dorsiflexed, the os calcis will stay out of the way of the ankle joint. If the foot is not dorsiflexed and the toes are extended like a ballerina, the heel will actually regress and tuck in behind the ankle joint and partially superimpose the ankle joint. So the reason for dorsiflexion is to get the heel bone out of the way of the ankle joint posteriorly. Okay. For our lateral ankle, you're just going to roll the patient 90 degrees. Now you could opt for a cross table if you want to minimize manipulation for trauma situations, and I'll show you how to do the cross table projections. Cross table projections of the foot and ankle are probably the easiest trauma adaptation you'll apply as an X-ray tech. You'll want to direct for a conventional lateral ankle, flex the knee just slightly, dorsiflex the ankle, center to the medial malleolus, exiting the lateral malleolus, and then again the foot, you want the foot intralateral, so the plantar surface is going to be perpendicular to your image receptor. Might have to build up the knee onto an ankle sponge in order to get the ankle in true lateral, and we've got a radiographic sign for that I'll describe to you in image critique, how you can tell whether or not your ankle is true lateral or not. Okay. Again, if we don't dorsiflex, we don't get an open joint space as well on our lateral ankle. Okay. We're going to use 40 inch SID. We want to include all the soft tissue around the ankle. Make sure you're not clipping the heel off. Open up the collimation so that you can see 4 inches superiorly to the ankle, 4 inches inferiorly or distally to the ankle. Include the base of the fifth metatarsal because, again, that's the site from last lesson. That's the site of the Jones fracture, and so we always want to include that in our radiographs of our foot and ankle. Dorsiflex, include all of the heel in the evaluation as well, and the Achilles tendon. The Achilles tendon posterior and superior to the heel, posterior to the ankle joint. You should be able to see the Achilles tendon in contrast to the posterior fat pad that's just superior to the heel. So there's a big pocket of fat, and then there's a thick cord that is the Achilles tendon that anchors the calf muscle to the tuberosity of the heel bone. And that can rupture. That's a common injury. So we want to make sure that soft tissue detail is included on our lateral ankle. Okay. If the Achilles tendon is ruptured, try not to manipulate the body part, and the patient might not be able to dorsiflex or plantar flex. They might not have much flexion extension motion involved with the ankle with a ruptured Achilles tendon. The Achilles tendon is what makes it possible for plantar flexion or extension of the ankle joint. Okay, for our oblique ankle, this is the one you won't be doing often, but you can do internal and external 45-degree obliques. Those are in the Merrill's Atlas. I have never done 45-degree obliques, but those are possible. The medial one is a little bit more diagnostic than the internal rotation is more diagnostic than the external rotation. So true 45 obliques of the ankle, those are within the realm of possibility, but those are not usually the obliques that are asked for. The usual oblique that is asked for, this is again the 45, it's a little over-rotated for what we're looking for. You get some distortion of the joint space. You get like the ankle is stretched or elongated in the transverse plane, and you might get a closing off of, see how it says the tibiofibular joint is open? That's not always the case. Sometimes you get that closing off again. You've rotated so much. And again, the space between the medial malleolus and the talus bone also sometimes closes off with this 45-degree rotation. The one we typically do is the oblique for Mortise, which is only 15 to 20 degrees of medial rotation to the ankle joint, and that seems to open up the Mortise space better and does not over-rotate, so you're closing off those spaces again, especially at that medial malleolus. Okay. The leg's still extended, so you basically you start out like you're centering for an AP, and then you roll the patient's foot in. Make sure you're doing that from the proximal end of the foot. Again, if you've had trauma and you apply torque to the patient's actual foot and they've had a fracture or a sprain, you might be exacerbating that injury. So apply a gentle rotation motion from the midshaft of the tibia and from the knee and the femur. Have them do the rotation at the hip and have that translate down through the entire leg. Okay. For your geriatric patients, you can use a shallow angle sponge or a rolled up bed sheet underneath the lateral aspect of the knee. That should keep this 15 to 25 degree medial rotation and keep the patient in that position. For pediatric patients, you might want to use a sandbag to hold them in place, or some tape, or the parent if they're available. Okay, so a nicer oblique is this one, what's called the Mortise oblique. This is the routine. You'll see the lowercase h. If you look for the black area of the joint space, it forms a lowercase h between the fibula, the tibia, and the talus bone. And that's how you know that you've got a proper Mortise oblique. Again, we want approximately 4 inches proximal, 4 inches distal to the ankle joint, and we want to see an open joint space all the way around around the talus bone and between the tibia, the distal tibia and fibula. Stress views of the ankle, that will be the physician that does this, and they will torque the ankle to extreme inversion and eversion. It's kind of like a radial and ulnar deviation, but applied to the foot rather than the ankle. It's to evaluate for sprain or tears of the ligaments. The physician will know how much to flex or to invert or evert the ankle, and a technologist should not be doing this independent of a physician. Okay, and so the foot is placed in a stressed position, and then the radiograph is taken while the foot is stressed in extreme inversion or eversion. So flexing the foot inward toward the midline or externally away from the midline to see if any of the, in particular, there's ligaments. It's called a high ankle sprain. You might have heard about it by watching the NFL. There's ligaments that connect the distal fibula to the distal tibia, and those can tear and separate and cause a partial dislocation of the ankle. And so that can be evaluated by stress views of the ankle. You can also evaluate it with MRI and not have to put the patient through possible exacerbation of the injury. So here's our first review question, possibly the only one. The ankle Mortise view requires how much obliquity? So what degree of body rotation do we do, and which direction do we do? I'll give you guys just a minute to review your notes, or maybe pop back a couple slides to figure this one out. And the correct answer is 15 to 20 degrees of medial rotation is the ankle Mortise view, or the Mortise oblique of the ankle. Moving into common fractures, I've already mentioned the most common one. It's got a couple names that it goes by, and then typically it's usually the same injury. Not always the same injury, but usually the same injury, just degrees of magnitude. So an ankle sprain going into a bimalleolar or Pott's fracture, going into a trimalleolar fracture, it's all the same force applied to the ankle in the same direction. It's just a question of how much did we mess up the ankle. Okay, so our bimalleolar fracture is going to be, yeah, you guessed it, we're going to fracture both the medial and lateral malleolus. The fracture of the lateral malleolus is usually more proximal than the medial malleolus. The medial malleolus is almost like an avulsion. You can't really call it a chip because that is a generous chunk of bone. Just like you can't call it a styloid, you can't really call it an avulsion. That's a big chunk of bone that is fracturing off on the medial malleolus. Lateral malleolus is fractured usually a little bit more superior, a little bit higher up than the medial malleolus. The book says, actually the internet says 6 to 7 centimeters proximal to the lateral malleolus, so it could be as high as the top of the radiograph. That's not what's demonstrated here, but it's within the realm of possibility. You also get a partial dislocation of the ankle because of the ligament tears between the tibia and the fibula. That's the high ankle sprain area that I was talking about, and that's the very top of the lowercase h. Okay. The way that this happens is excessive medial torque or force is applied to the foot and ankle. Okay, medial to lateral force. So the patient lands on their foot incorrectly, and the foot rolls externally. as the force. Typically, it's the force of the patient's body weight. In the case of football, it's patient's body weight plus the tackler's body weight, and the foot doesn't land square, it lands externally rotated, and the ankle just buckles and can't withstand the torque applied, the twisting motion applied to the ankle. So with a small amount of force, this is how you get a sprained ankle. With a medium to large amount of force, this is how you get a bimalleolar fracture or a Pott's fracture, which is what's shown here. And then with an excessive amount of force, with the largest amount of force, you actually get what's called a trimalleolar fracture, which might be surprising to you because you didn't know that the ankle had 3 malleoli. And it's just a special nomenclature for this type of fracture. The posterior tubercle is being counted of the tibia, and I'll show you that to you as we go through the anatomy with the skeleton, the bones in the bin up front. The posterior tubercle is avulsing or shearing off, as well as the bimalleolar fracture of the medial and lateral malleolus. Also, partial dislocation, high ankle sprain. A lot of times with a trimalleolar fracture, you can see the talus bone shifted aggressively laterally relative to the tibia and fibula, to the extent I've seen it where it has impinged the blood supply to the foot. That's how bad a trimalleolar fracture can get, where the talus is basically hanging out beside the tibia rather than underneath it, and the entire foot is foreshortened. If you have bi or trimalleolar fractures, first of all, the patient is going to be in extreme amounts of pain. There should be aggressive soft tissue swelling. You're going to see inflammation response, and you should avoid any time the ankle is swollen up so that it's just as big as the knee. It's big and angry and red, and it's about 3 times the size you're expecting, or 3 times the size the uninjured side, because people in the lower extremity can have poor circulation and such, so they can have foot and ankle swelling that is non-traumatic. But if you have traumatic inflammation response and the affected ankle is 3 to 4 times the size of the unaffected ankle, I would divert to a non-manipulation protocol and try to take ankle x-rays without moving the body part aggressively, and no twisting or turning or rotating of the body part to get the 3 pictures of the ankle. All right, so that was how to do an ankle and the common fractures of an ankle. And again, we'll go into those trauma protocols as we're doing the demonstrations and as we're walking through. I'll show you the routine views, and perhaps as a critical thinking exercise, you guys will show me how we're going to do adaptations to prevent us from manipulating the part aggressively during a potential fracture of the ankle. All right, so moving on to the lower leg. Again, let's review some of the anatomy. Your lower leg has a weight-bearing bone, the tibia, and a non-weight-bearing bone, the fibula. The fibula is more so to carry on. It doesn't really act with the same pivoting motion as the radius does, but it does pivot slightly. It kind of carries on the inversion and eversion and the medial rotation and the lateral rotation of the foot translated from the hip. So the fibula is critical in keeping that motion moving through the entire lower extremity. And you can do that right now in your chair. Just extend your leg out in front of you and rest your foot down on your heel, and then move your hip, and you will see that you're rocking your foot internally and externally, and it's all motions of your hip, not really motions of your foot and your ankle. And so the fibula is critical in keeping that motion going all the way down, and providing some of that. That's why the ankle appears to be an ellipsoidal joint when it is in fact a hinge joint. Okay, the tibia, second largest bone in the body to the femur. The fibula, however, is not weight bearing. Okay, if you're trying to bear weight on your fibula, you're going to have a bad time. That's how fibula fractures go by and large. Is if the tibia breaks, the fibula will necessarily break in the next instant, because the fibula is not meant to bear the weight of the body. Only the tibia is rigid and structurally sound enough to bear the weight of the body. All right, so both the tibia and the fibula are long bones. There's proximal and distal ends. This is gonna very much mirror our understanding of the tibia, understanding of the humerus maybe, or understanding of the radius and the ulna in the forearm. There's going to be piece parts at the proximal and distal ends. Not a whole lot of anatomical landmarks in the diaphysis, in the shaft of the tibia. There is an anterior spine to the tibia. It's kind of a prominent ridge on the front end. All right, so at the proximal end, which forms the knee joint, and we'll go back over this in the knee joint. We've already covered really the distal end of the tibia. It's the medial malleolus, the inferior surface. There's a posterior tubercle, and then there's a fibular notch on the medial side of the tibia for the articulation with the fibula. But at the proximal end, there are medial lateral condyles, which are rounded surfaces that are articular extremities. The superior surfaces of those condyles form facets, which are called the plateaus, and that's where the menisci sit on those plateaus to articulate. The menisci are pillow-shaped cartilage pads that cushion the knee in between the femur and the tibia. You have a lateral compartment and a medial compartment, and we'll go through all of that in the knee joint. The landmarks and the anatomical structures on the proximal tibia include the medial and lateral condyle. There's the plateaus, the articular surfaces. There's an intercondylar eminence that is just it's a kind of a double protrusion, almost like two mountain peaks sitting in the middle of the tibia. Those are the tethering points for the cruciate ligaments that we'll see in the knee chapter. And then on the anterior surface of the knee, the tethering point for the subpatellar tendon is the tibial tuberosity. So the quadricep muscles terminate at the tibial tuberosity, and those are anatomic landmarks of your proximal tibia. Now, while we're here, the proximal fibula has a head, an apex, and a neck, and we might see that on the next slide. No, it just continues talking about the tibia. So there's the mentioning of the tibial tuberosity. It says serves as a point of attachment for muscles. In particular, the muscle, the major muscle group that attaches at the tibial tuberosity is the quadriceps tendon. And I did mention that it's also called the subpatellar tendon. The patella is a sesamoid bone that forms in the quadriceps tendon. And so it's completely enveloped by the quadriceps tendon. And then the quadriceps tendon tethers and attaches. So when you flex your quads, you're actually pulling the front of your tibia up towards your hip, and that straightens your leg. Tibial tuberosity is also the site of a adolescent pathology that I happen to suffer from. It's called the Osgood-Schlatter's syndrome or disease. It is where the growth plate for the tuberosity separates and avulses a little bit. The tuberosity actually pulls free from the anterior tibia, and you get a more prominent tuberosity when it does eventually heal and scar over. But that's because the tendon is not, the femoral tendon is not growing as fast as the tibia is growing in an adolescent male. And the tibia actually just grows away from the knee joint too fast. And you get a separation of the tibial tuberosity from the anterior tibia. So in our distal tibia, we do have the fibular notch, similar to the radial notch on the proximal ulna. So the fibula slides into and fits into the fibular notch, forming the distal tibiofibular joint, which is the top of the ankle mortise joint that we saw in the ankle radiographs. Okay. And of course, the mortise proper surrounds the talus, the superior aspect of the talus bone. Okay. Our fibula is also a long bone. Mentioned previously, it does not bear weight. It has both a head and an apex. The apex is like the pointy, almost like a styloid, but again, too large for a styloid, I suppose. So we call it an apex. The head is the widest part underneath the apex, and then there is a neck underneath the head where it tapers into the diaphysis, and the neck of the fibula is the most common place of fracture aside from just superior to the lateral malleolus. Yeah, the apex and the head do articulate with the medial condyle at the posterior aspect of the medial condyle of the tibia. And so there is a proximal and distal fibular tibular articulation. Tibulo-fibulo, however you want to say it. The two bones articulate both at the proximal and distal ends. The fibula actually runs through the calf muscle. It runs through the gastrocnemius muscle, which is a strange type of arrangement. Usually the muscles are on top of or surrounding the bones, but not in the fashion like the humerus is the proximal humerus is completely surrounded by the deltoid muscle, but none of the humerus protrudes through the top of the deltoid muscle, whereas the fibula, the diaphysis of the fibula penetrates through the gastrocnemius muscle, but the head and the apex of the fibula are not shrouded by the gastrocnemius muscle. It pokes out the top as if the fibula has stabbed all the way through your calf muscle. It's kind of strange that way. No, I don't know of another muscle group that's kind of like that arrangement of the fibula and the gastrocnemius muscle. Generally, when you're x-raying a lower leg, it's very rare to have a standing exam. Typically, the reason you're x-raying the lower leg is suspicion of fracture. So it's often going to be a trauma with a cross-table projection laterally, possibly removing a splint, making sure you're getting permission to do so. If the physician does not want you to remove the splint, then you just take the radiographs with the patient in the splint, understanding that there are going to be metal bracing rods or stabilizing rods as artifacts. There's not much you can do about those in the artifacts. They're typically posterior in the boot, in the Velcro boot that you attach to the lower leg. Typically there's 3 steel or aluminum rods running along the posterior of the leg for that stabilizing boot. So lay the patient down, extend the leg, keep the knee straight for trauma radiography. You might want to elevate the leg for the cross-table projections. And again, it's always within the realm of possibility that you'll be doing an upper and a lower, very much like you do an abdomen or a femur, depending upon the size of the patient and the size of their lower leg. So start out with a 14 by 17 cassette and try to, if they're small enough, try to include it all on one. Different facilities will allow you to go diagonal with the orientation of the cassette. Some of them will not allow you to go diagonal with the orientation of the cassette, so just be mindful of that. Okay. You do want to maximize comfort. Again, the tibia and the fibula are being evaluated because of the possibility of fracture. If the patient is in a stretcher, you do not have transferring them to the table. Doesn't really add anything to the x-ray, so a transfer is often unnecessary because the tibia and the fibula can often be evaluated with tabletop projections. Okay? You will use a grid on your hypersthenic patients, but a stationary grid is perfectly acceptable for a tibia-fibula evaluation. And so it's not necessarily necessary to do a table Bucky examination for the tibia and fibula. Okay. Your collimated field size, you're going to start out with a 14 by 17 cassette. You may arrange it diagonally if allowed by facility protocol. You may have to resort to uppers and lowers. If that's the case, you can typically go to a 10 by 12 cassette to capture the remaining anatomy that's not included on the first projection. So your guidance for that first projection is the area of injury should be included with the nearest joint space, just in case it is. So let's say they've have a fracture of the shaft of the tibia and the fibula, but it's closer to the ankle than the knee. Then you would get a 14 by 17 AP of the tibia, starting at the ankle, including all of the ankle and the foot, and as much of the shaft of the tibia going past the fracture included on the first projection, and then follow up with an AP knee radiograph or a proximal tibia radiograph that doesn't include the fracture on a 10 by 12 cassette as the second exposure. So always the big exposure, the bigger field is always the area of interest, the area of the injury, the localization of where you think the fracture is, or where you think the contusion is or the trauma is, and the nearest joint space included in one radiographic exposure. Okay. If they have hardware, orthopedic fixation, internal orthopedic fixation of the tibia or the fibula at the ankle or the knee or what have you, the entire hardware must be included in the radiograph. And so you might have to get additional projections to include all of the orthopedic hardware. Okay. You must use a radiopaque marker. You must properly identify the patient, obviously, in the final images. You should, as a safety check, as you're doing your final image critique, confirm that you have, in fact, taken x-rays of the right side, the correct side of the patient's body. You annotated that correctly, and you have the correct patient identity on the radiographs before you send to PACS. Okay. Additional digital annotation, while it's an available tool, should not be relied upon to indicate the side of the body, as that can be altered post-exposure and does not meet the legal standard. All right, radiation protection should be able to shield all your patients. The ankle and lower leg are nowhere near reproductive organs. There is no harm in applying a shield, except that maybe it prevents your x-ray tech from going back and sipping on their coffee, and their coffee might get a little colder because they took the time to protect their patient from ionizing radiation. So other radiation protection measures, shielding is not the only radiation protection measure. You can limit exposure to the tissue by choosing to limit your field of view to only the anatomy of interest. Okay, so follow the collimation guidelines according to facility protocols. It should be, for long bones, it should be open the collimation to include the surrounding joint spaces, that is the entire ankle joint and the entire knee joint. But we don't need half of a femur on a tib-fib exam. We don't need the entire foot on a tib-fib exam. Okay. First of all, the foot in an AP tib-fib, the foot's non-diagnostic and self-superimposed. So opening up the collimation to include most of the foot, you can definitely tell it's dose applied to flesh without cause, without diagnostic cause, because it's a non-diagnostic view of the foot. The foot has to be x-rayed from like a dorsoplantar projection, like the AP axial, or an oblique. X-raying, having x-rays enter the toes and exit the heel, it superimposes everything in the foot with everything else in the foot. And so close your collimation up to just beyond the malleoli, about 1 inch beyond the medial and lateral malleolus is perfectly sufficient for a tib-fib projection. Also open up to the femoral condyles. That's plenty for the femur. If the ordering physician wants diagnostic views of the ankle and the knee, then they also order ankle and knee x-rays. Okay, so include the joint spaces to say that we've included the joint spaces, but you don't need to include any of the foot anatomy or any of the none of the foot anatomy and none of the femur anatomy has to be diagnostic. The exception, I guess, would be a total knee replacement. You do want to go back and open up the collimation to include both both of the knee replacement prosthetic implants in their entirety. All right, your patient instructions. You're going to need them to hold still. There's no breathing instructions. We're not close enough to the torso and the trunk to require a breathing instruction yet. In the cases of trauma, you really want to make sure that the patient is comfortable. And for those cross table projections, you want to support the heel with additional padding, just in case there is a fracture at the ankle or in the midshaft of the tibia. The foot will be dangling, and that will be painful and necessarily will exacerbate the injury if you don't support below the fracture. So put some padding under the knee, put some padding under the heel, and support on both sides of the fracture if you are doing cross table projections and building up the body part off of the table. Okay. Remember, a more comfortable patient is going to hold still better than an uncomfortable patient. Okay. I think this is a mistake. Yeah, that's not supposed to be in there because I'm not going into the knee just yet. Let's see, projections of the leg. Yeah, here we go. So there's your projection of the leg, mid shaft, halfway between the knee and the ankle. Okay, halfway between the two bendy parts. That's how we image long bones. So perpendicular to the mid shaft, going to open the collimated field to include the knee and the ankle joint. Okay. The long axis of the body part, the tibia and the fibula, are running parallel to the image receptor and perpendicular to the central ray. Okay. We do want to dorsiflex the foot so that the ankle joint opens up. We want to extend the leg, and we want to rotate the knee so the condyles, both femoral condyles, are equidistant to the image receptor, and that puts the leg in a true AP position. Okay. For our lateral projection of the leg, what happened to their other leg? That is quite a flexible patient there. That's crazy that you don't even see any of their other leg. They're either very, very flexible or they're an amputee. You are going to have to deal with the unaffected leg. Usually I bring it forward of the affected leg, and that gets me to a better lateral of the downside extremity. I also slightly flex the knee to relax the calf muscle. The knee is the muscles around, the major muscle groups around the knee are fully relaxed at about 20 degrees of flexion. And so we definitely do that for a lateral knee, but we can also include that in a lateral tib fib. So long as the patient can bend the knee, have them flex it slightly, they'll be more comfortable. And the muscle groups, the calf muscle will be relaxed, the anterior tibialis muscle will be relaxed. Dorsiflex the foot again to open the ankle joint space. And then you want the femoral condyles to be superimposed with each other and perpendicular. So you want to draw a line through the femoral condyles and epicondyles, and that line should be perpendicular to the image receptor. Okay. You should find that the plantar surface of the foot is not exactly vertical for a lateral leg. It's slightly tipped or rotated. So the foot, while the foot is true lateral, the tibia is not, and the knee are not true lateral. So now we're more want the knee and the tibia to be true lateral. So we dorsiflex the foot. You should see that the lateral malleolus runs posterior to the medial malleolus if you have the lower leg in a true lateral position. And that's one of the radiographic signs for the lateral ankle. Right? So here we go. Yeah, you can see the lateral malleolus runs posterior to the tibia. It should superimpose on the posterior half of the distal tibia. Okay. Again, if your facility allows you to do crosswise or kitty corner projections to maximize the diagonal of an image receptor is always longer than its longest side. That's the Pythagorean theorem. The hypotenuse is the longest side of the triangle, and the hypotenuse is the diagonal of every rectangle, is a hypotenuse of a right triangle. So the diagonal of the image receptor field is the longest dimension of that image receptor. So if you're having trouble fitting someone with a long tibia, and the facility protocol allows you to, you can rotate the cassette to a diagonal. Just make sure the tibia is leaning the same direction for both the AP and the lateral. That'll help the radiologist. And if you can, use the rotation software to stand the images up once you send them to PACS. Don't leave them rotated diagonally if you can help it. Sometimes that does affect spatial resolution, but most of the times it's not a significant change to spatial resolution that you have to worry about it. But again, check with facility department protocol what your radiologist prefers. If the radiologist says absolutely no rotation of the images and they do not want diagonal tib fibs, then you have to do uppers and lowers with a follow-up 10 by 12 spot of the unaffected area of the tib fib. All right, so yeah, that's it. That's all that we had for the ankle and lower leg. The lower leg very much like the forearm. Now occasionally you do see someone that wants trauma oblique views of the lower leg, and I'll just mention this in passing. You're not going to find those in Merrill's Atlas. Just do, I would do a 15 to 20 degree oblique. I would give them a bonus ankle mortise, but for the entire lower leg if they wanted oblique views. So I'd do an ankle mortise, and then maybe I'd do a 45 external oblique rather than doing, because which oblique do you do? If it's not even mentioned in the Merrill's Atlas, well, you would do the one that's most diagnostic, which is the ankle mortise 15 to 20 degree medial oblique, if it's ever called for. So it's rare that you get a request for an oblique tibia or lower leg exam, but if you do get that request, just give them a 15 to 20 degree medial oblique, because that's probably what they're wanting to see is a mortise view of the ankle. So, all right, that's all. I will see you guys in the laboratory for this one. Y'all take care. Happy New Year. Finishing up our break week here. It's Friday of the break week. I've got one more recorded lecture to do before I head out for New Year's weekend. So y'all take care, and I'll see you in class.